All right, it is 2 o'clock, so we're going to go ahead and get started with our webinar. We're so excited to have you here today for our webinar on sliding fee discount program with Elizabeth. Thank you all for joining. Just a few housekeeping items. This webinar will be recorded and posted on our YouTube page, so you can refer to that at a later date. And our webinar slides and recording will be sent out tomorrow via email. Without further ado, I'd like to introduce Elizabeth for today. Elizabeth was an alumni of DePaul University and then received her Doctor of Jurisprudence at Indiana University Maurer School of Law. She worked at the Indiana State Department of Health as the director of the State Office of Rural Health, where she more than tripled the amount of funding received for critical access hospitals. She then returned to Cayuga, her hometown, to start up and serve as the founding chief executive officer for Valley Professionals Community Health Center, which grew over 1,000% in her 8-year tenure. As her principal of Burrows Consulting, she has established 80 and more FQHC lookalike service delivery sites and consulted with over 40 FQHC grantees on their operations policies and sliding fee discount program. I'm so excited to have her here today, so I'll turn that over to her.
Thank you, Hannah, and we're excited for a great turnout. Definitely some names that I recognize and some new names, so we're excited to have you join us if this is your first webinar, and feel free to reach out if you have questions. Also, if you do have specific questions, you can put them in the chat at any time, and we'll be glad to answer those at the end of the presentation. You can also email Hannah, and she'll be getting back with you on those as well. And if you email her during the session, hopefully we can get to that at the end of the day. So again, thank you for joining. I know the topic may not be too exciting, but sliding fee discount schedule. It is extremely important for both federally qualified health centers and rural health clinics. When I say federally qualified health centers, that means both FQHCs and FQHC lookalikes. Additionally, it also includes rural health clinics and any clinics or facilities receiving National Health Service Corps loan repayment for their providers or have National Health Service Corps scholarship recipients. This is one of the things that actually HRSA has the same rules across the board. So it's the same for whether you're any of those entities. Some of you might be multiple. You might be both an FQHC and have National Health Service Corps loan repayment. You might be a rural health clinic and also have National Health Service Corps scholars. Any of those combinations are fine, and the same rules for sliding fee discount schedule do apply. Today, we're going to go over exactly what is involved with the sliding fee discount schedule, how to involve your board of directors, or if you call it an advisory council, an advisory board, or anything. I am using HRSA's terms with the board of directors. Sliding fee and all your memorandums of understanding or MOUs or memorandums of agreement or MOAs, and making sure you have full compliance. How to inform your patients about the sliding fee, and how to involve patient navigators, community health workers, or any of the other staff that interact with our patients in promoting the sliding fee discount schedule. So those are what we're going to talk about today. Again, we welcome any and all questions and interactions, and hopefully, again, you're able to learn one thing and take that back to your clinics, your health center, wherever you're delivering care, so that you're able to implement that at your facilities. All right, so what is a sliding fee discount schedule? To me, that confuses people, right? If we hang up a sign in our waiting room that says sliding fee discount schedule, unless you are in this area and you've worked in healthcare and you've been aware of what's happening, it is confusing. To me, it simply means fees based on family size and income. And I'm going to repeat that again. I really think that resonates better with the patients that you serve and with your communities, that fees are based on family size and income. In that sense, it's similar to school lunch, right? We all grew up knowing that different people pay different amounts for school lunch, but yet they receive the exact same school lunch. That's the exact same thing with sliding fee discount schedule, in that everyone's receiving top quality care at your health centers, but they do pay different amounts based on their family size and the income of their household. So again, a sliding fee is for this particular setup, and to meet all HRSA guidelines, is for patients at 200% of federal poverty level or below. Please keep in mind, and it's extremely important, that the federal poverty level guidelines do change annually. You pretty much always get the new guidelines in the first quarter of the fiscal year, so between January through March. This year, they came out fairly early in January. I usually see them come out in February, but either way, you are expected to keep up with these. So as soon as those are announced, you need to be updating your sliding fee discount schedule. If you are sitting on this call and you're like, oh, wait, ours hasn't been updated since last year, or even worse, ours hasn't been updated since we had our initial FQHC lookalike site visit, or ours hasn't been updated since we had that National Health Service Scholar 3 years ago. You need to pull it out and check and make sure that it is on the 2023 annual guidelines. If you are a federally qualified health center, this would need to be passed by your board of directors and updated regularly. So you want to make sure to stay on top of this. For me, it's always putting a calendar reminder, say February 1st or January 15th and February 15th for the next year to say, hey, check the federal poverty guidelines. Typically, you do get a notice. There are different ways that HRSA announces it on their Instagram page, through emails and things like that, but you always want to make sure that you have this most up to date. Heaven forbid they update the federal poverty guidelines and a week later you actually have your rural health clinic site visit for designation. That would not be a good day, right? So you want to make sure you always stay on top of it. Again, the goal is, even though there are some complications with this and sometimes setting it up in your practice management system or with your electronic health record can be a little bit of a challenge. This is important because it does make sure that you provide a safety net to low-income patients. And again, FQHCs, lookalikes, and some hospitals have to have this for their services and for all services that they provide. We're going to talk about that here in just a second. Also, please keep in mind, these are suggestions. There are lots of ways to vary it up. So what I'm saying today, if you do it slightly different, that's probably perfectly fine. There are multiple ways of doing this and being fully compliant. But again, the goal is that you are offering discounts in some form or fashion to those patients at 100 to 200% of the federal poverty level. Discounts, and then you're offering a nominal fee for patients at 100% of the federal poverty level. If you are in a state that has Medicaid expansion, which is about, I think, just over 2/3 of our country, some of those patients that would have been on the nominal fee may now qualify for Medicaid. You'll definitely want to do that if that's the case, so they can access other services, but you still always put them on the sliding fee scale. Next slide, please. So this is an example, and again, they all can be different. Many of the EMR platforms do this for you. Some of them automatically update. Sometimes you have to press a button to get them to update. But again, no matter what, the point is you have income class levels. You have to have at least 3. This one does have 4 to meet HRSA standards. But again, at 100% and below, you're paying a nominal fee. And at 200% and above, you're paying full fee. Most places, and it is encouraged, strongly encouraged, though not yet required to my knowledge, that even if patients do have some form of insurance and they still can qualify for the sliding fee scale, you will want to make sure to qualify them. So for example, if they are a member of, say, the working poor, or they do live at, say, 150% of federal poverty level, but they may have some form of insurance, usually oftentimes it is a high deductible health plan, that you still can bill that insurance for services, but patients may only then have to pay $40 for their medical visit instead of the full fee because they have not yet reached their high deductible. That's where really all of you, RHCs, FQHCs, National Service Corps recipients, can really do some great outreach to the community. You talk about a patient pleaser. If they are out working hard but still can't access care because of high deductible health plans, they will be thrilled when maybe they only have to pay $15 for a dental visit or $30 for behavioral health. Again, this is an example that we've used. Oftentimes I do see behavioral health being cheaper than dental and medical being cheaper than that. This is just an example. If your amounts are totally different, that's fine. It is meant to be a nominal fee based on your community. So my community may view a nominal fee differently than your community. For example, where I live in rural Indiana, the nominal fee is probably going to be lower than Los Angeles, California, where the cost of living and the cost of everything is much higher. So just keep that in mind. Also, I often get asked, can the nominal fee be zero for 100% and below? Yes, the nominal fee can be zero. That is perfectly allowable. That is up to you and your board and your clinic leadership team to determine if that is reasonable. Now, we can sit and argue all day about whether people actually appreciate things if they are free, and we could argue that all day long. So I do think there is personally some value to making sure the nominal fee people do pay something, because sometimes we don't value things that are free. But again, 100% up to you. It can be free or it can be a fee that is determined nominal. So again, the requirements. First, your discount schedule must be prepared based on local rates or charges to determine your reasonableness. So you can't go in and say, well, I'm a rural health clinic or an FQHC and I'm making more than the private practices, so I'm just going to charge less for everything. So a 99213, great, it's $50. No, you cannot do that. Your fees for those visits, those E&M codes have to be reasonable, and they have to be the prevailing rates, and that if you were fully paid for them, they would reasonably cover your costs of operation. In other words, if you weren't getting grants and other sources of income, that again, you would be able to keep your doors open. Second, you must provide a discount to individuals and families with annual incomes at or below the federal poverty guidelines, or 200% of that. And as we saw in the previous slide, that actually can be a pretty nice income. It could both people could be working, or again, a single mom with a couple kids still could qualify based on the guidelines. You can set the same charges for all services or have different charges for medical, dental, behavioral. And again, that's a choice your leadership and your board have to make. And again, for HRSA requirements for FQHCs, you must review the policy and the charges every 3 years at a minimum. Again, just for clarification, that's reviewing the policy every 3 years. I suggest as a best practice that you have your board update that in the first quarter of every year, and you review that policy every year. This is technically the minimum HRSA requirement, but again, I do believe annual review is by far the best practice and probably the way that you want to go for your health center. Now the fun part, how do we involve our board of directors? And when I say that, it also may include involving patients. It might include involving your leadership team and your staff. Again, if you are setting your sliding fee and you're never talking to your front office staff that interface with patients and that they're the ones collecting payments, you're probably missing out. You want to make sure that you are involving those people that have those direct interactions with board members, with patients, with the community, so that way you're hearing those things. So again, the board must evaluate and approve your policy and the schedule. And again, the policy must include certain things. One is the methodology, required patient documentation, and procedures for assessing patient eligibility. So however you set that, for a lot of people, that is turning in the previous year's income tax report, and that people use that, or pay stubs. I've often heard, and even at my own health centers, I had complaints because someone would say, well, that person cleans houses and they make a lot of money. They drive a Cadillac to our health clinic visits, but yet they qualify for sliding fee. Well, again, I can't control what they report on their taxes or if they're getting paid cash for doing work. If it's not reportable on the taxes, and if they're not officials pay stubs or they're not receiving W-2s, yes, they might be getting rich doing cash work, and there's no way of changing that. Again, very similar to qualifying for free lunches at school. I know some of my kids' friends have, they say, well, their friends get free lunch, why don't they? Well, again, it's all dependent on how you claim your income. But again, you need some form or fashion to determine how you're going to count that. You also need to have, the health center must communicate the availability of the sliding fee discount program to patients. We're going to talk a little bit more about that later in the presentation. And also who is responsible for reviewing and approving patient applications. So again, you want somebody that actually can review the documentation, ensure what the patient is saying regarding their income is correct, and qualifying them for a set amount. Again, you can provide a 100% discount or a nominal fee. For the nominal fee, it needs to be nominal in the view of patients. So you either need to include that on your patient feedback and surveys. You must show that you've gotten input from patient board members and advisory committees, or that you've reviewed it based on local income data. So you really need to make sure that that is reasonable. The easiest way to meet this requirement is by adding it as a question to your sliding fee scale and say, if you do qualify for our sliding fee discount program, is our nominal fee of such and such amount reasonable for you? Mark yes or no, or comment. And again, for health centers, you will want to store this feedback for all people, National Service Corps, RHC, and FQHC. Store this feedback so you are ready for any site visits that you have in case you are asked this. Now, this becomes the first part is kind of the easier part. Now we get to the harder and more complicated section. And that is for all services that are on your Form 5A. And again, those are the services that you provide as a health center, or the services that you have designated as a rural health clinic that you provide. You need a contract or formal referral agreement that makes sure to provide for the sliding fee discount program for your patients. So again, for all in-scope services performed by contract or referral agreement, patients under 200% of federal poverty level need to have discounts for services. An example of this might be inpatient at a hospital, laboratory services, translation services, dental services, anything that you contract out. This applies even if the contracted provider offers patient assistance or sliding fee. You always want the lower charge. You don't have to have discounts if they're over 200%. Now, you might say, Elizabeth, I cannot control what the hospital charges. That's exactly right. So you can look at their charity care policy or their sliding fee scale and have your board adopt that for services provided. So again, don't try to make it overly complicated as long as they are serving everyone. And again, HRSA's goal is for the full continuum of care for patients to be provided that you have provided for that. You need to have language in your agreement. The reviewers will be looking for that to clearly define who is paying and how that is being taken care of. Another hint, if you are, say, contracting with another FQHC for dental services or for behavioral health services, you would also want to include their sliding fee scale in with their agreement. So print that off of their website, get a copy of that from your partner, however you can have that. So that way when HRSA is there for their site visit, you're able to show that. It's also helpful because if you are asking that your board adopt yet a different sliding fee program for a different service, that you are able to have that available and your board can see that that is reasonable fees, because you want to make sure that everyone has access to the full continuum of care. FQHCs, RHCs, and National Health Service Corps sites are safety net providers, and the goal is for all patients to be served no matter their ability to pay. All right, now this is the fun part, and this is the part that sometimes trips us up, and sometimes it's the easiest amount. But make sure that you are communicating to your patients, and patients are aware that you do have discounts available. You are responsible, and your staff are responsible for making sure people understand the potential discounts and that they are communicating that to patients. I was at a health center about a month ago, and I was sitting waiting to go back to meet with the CEO. During that time, I heard someone come in and say, well, I had insurance last time I was here, but now I don't. Will you still serve me? And the front office did it exactly right. They said, yes, of course, we'll serve you. Here is some paperwork to fill out so we can provide you the proper discounts for services. That's exactly right. That's what you want to do. So make sure that you are providing information and people are making that known. You need clear posted signage. Make sure that that is understandable. It's in proper languages and in your registration form so people know this discounts exist. Again, making sure it's in the language of where your patients are and that they do understand it. That's why I like saying fees based on family size and income much better than I like saying sliding fee discount program. That is a personal viewpoint, but again, you want to make sure that all patients do understand what they could benefit from. Also, please put this on your website, your Facebook page, your social media feeds. When HRSA looks at all of this stuff prior to your site visit, if they've seen that you are promoting this, that will be a plus for you. It's also a way to recruit providers. Some providers do want to work where you serve everyone, regardless of their ability to pay, specifically National Service Corps scholarship recipients and others. So that may in fact be a way that you can publicize your services and maybe even recruit providers to your area. You want to ensure that patients know there is an annual income verification, and they will have to provide documentation every year in order to keep and maintain these discounts. It is not a one and done. It's not, hey, I'm going to qualify once and then I don't have to do anything else and I'll always get care for $10 per visit. No, this is something that must be reevaluated. Next. This is how to involve your navigators, your community health workers. And when I say navigators, community health workers, I'm using those terms really loosely. It can be nurses, front office staff, patient service representatives, whatever it is that you call people. But again, making sure you have someone who can assist patients in applying for this application, who can explain and collect the required income verification. Again, keeping in mind cultural and linguistic barriers. So for example, my clinics that I used to run worked a lot with the Amish. Many of them don't have photo IDs due to the requirement of a photograph. They don't take photographs due to some of their religious beliefs. So again, requiring that is not something that they want to do, but they might be able to provide other proofs of identification. You also ideally have navigators that can link people to other services, whether that's temporary assistance for needy families, SNAP, food stamps, WIC, Medicaid, get them signed up for Medicaid or Medicare and meet all of those needs. You also want to make sure you can communicate any challenges experienced in the application process to your administration so that those things can be changed. Walking people through it may reduce the barrier if people cannot read. Trying to be as easy as possible with people to show their documentation, having people bring in letters or information from people they might be living with or providing them support. Anything that can simplify the process, that's exactly what you want. You also want to make sure any patient healthcare needs are presented to the clinical staff to ensure that you do provide the proper care for patients. You don't want patients to assume they've told you something and then they fail to tell the doctor, assuming that information was communicated if you are a navigator or a community health worker. So again, these people are extremely important. And I will tell you, during your HRSA site visits, they will talk to front office staff, and you'll want to be aware because they will actually ask them how they qualify them for sliding fee. And that is something that you may even have to do virtually through a laptop for your HRSA site visit. This is also something that I've heard is coming up in some RHC site visits. So you want to make sure that you are aware of how to do this and that you have a staff that are comfortable with this. Next. Here's some more important information. I wasn't sure how to classify it, but just some things that we need to go over and make sure you understand. Waiver and or reduction of fees. If you are, again, a federal center of any of the kinds that we've talked about, you want to make sure that you have a method for waiving and reducing fees. You need to also show examples of where you've done it. This is a newer thing that HRSA is following up on. So have you waived fees for someone who has had a sudden job loss? Something's happened, a tornado, a hurricane, a pandemic. Anyway, anything has happened and they are in dire need and you need to provide them health care. You need to have a method for waiving those fees and showing that you have in fact done that. Also, again, we mentioned this earlier, but it is very important. You need income verification every year and how you're going to make sure that this happens on the date. Some health centers re-verify every calendar year. Some let people do it for the 12 months and they can put flags and notations in their system so they know when people's year is up. Make sure you are evaluating this every 3 years and updating your federal poverty guidelines every year. Make sure that you're providing records. How many patients are actually utilizing sliding fee? What are the income levels of people? Even if they have insurance, you want to make sure that you are tracking what the income levels are. That is a UDS measure. Has the number of patients enrolled in sliding fee increased or decreased? Why? Are you actually following your own policy? You know, sometimes it makes sense when you're running clinics, be a patient. Go and get certified, take the documentation, or walk through with a patient and observe. What challenges did patients face in accessing sliding fee, and what did they face with the enrollment process? Have an outside person look at your website. Have an outside person look at your signage, that walking in that they don't see it day in and day out. Does this make sense to them? And do they understand what you're getting at? And again, watch for the new federal poverty guidelines every January and February timeframe. All right. And as always, feel free to contact us at any time. I think we've had some questions come in, and I'll be willing to answer any of those. Feel free to put additional questions in the chat, or you can unmute your line and ask me those questions. So Hannah, do we have any questions that have came in?
Yes, we do. Thank you so much for that. Our first question that came in was, many of our patients are hesitant to share their financial information with our staff, and HRSA says we need more people participating in the program. How do we overcome these barriers and get more people to apply?
That's a really, really good question. Here's a few of my ideas, but again, if some of you on the call have other ideas, feel free to put what you've done in the chat or unmute your line and share your experience too. One thing we did on our enrollment forms is actually to put at the top, please complete all questions. This helps us bring more federal dollars to your area, or this helps us bring more federal dollars to provide more services to your community, to your hometown. That way people understood, hey, this is why they're actually asking this, even though I may not have to answer this at a typical doctor's appointment, such as veteran status or income level. So definitely encouraging people with that. And just to fill that in. If they don't fill it in, to actually ask, can you fill in the highlighted areas that have been left blank? Giving it back to them so that way they do feel some pressure to complete that section. Another opportunity is just to go over it with them when you sit them down in a room and you just talk through all the questions. If you can have a navigator or community health worker to go over that with patients, you are more likely to get that information. And also just encouraging it through signage. Please ask us about discounts. Please ask us how to better provide services for you, those things. So maybe you are able to articulate that. If you have a pharmacy, also posting it at the pharmacy, whether it's in-house or somewhere else, but we do offer discounts for our patients, for our FQHC patients, or for our qualifying patients, things like that, because people are used to seeking discounts at the pharmacy. But again, just having it on the initial paperwork and explaining why can help. Also, maybe telling people when they make their appointments, hey, come in early. We have a pretty extensive intake process and we want to walk through so we can provide you all the best services possible, including potential discounts. Just articulating that from the beginning. Thank you.
Awesome. Thank you. Do we have anyone else on the call who has ideas or how they've overcome this challenge in their own practices? Feel free to unmute, drop in the chat.
It is definitely a challenge. And I understand in rural areas, people will be like, well, I'm not going to tell my income because I don't want that person to know what I make. And I get that. But I think just articulating, hey, this is important, and maybe even reminding people, have signage, any information shared at the health center is kept confidential, letting people know that. Again, putting out social media posts, putting information out to remind them of their privacy protections and the importance of sharing this information so you can better serve them.
Thank you. Another question we had come in was, from a policy standpoint, what are the biggest issues you see with sliding fee discount schedules?
Definitely, number one issue is people not following their own policies. So it says you do an annual review, do an annual review. If it says you do a review every 3 years, do your review every 3 years. If it says that you waive fees, make sure you have examples where you waive fees. If it says that you meet with patients to qualify them for sliding fee scale and you take certain documentation, make sure you do that. Failure to follow your own policies is always usually the number one thing that health centers miss. And I see it happen over and over with FQHCs, lookalikes, and rural health clinics. So again, review your policy and make sure you're doing what it says. Another big issue are people not seeking patient input for the nominal fee. They just say, well, this is the nominal fee that the other health centers in the area had, or this was the nominal fee that they had when I took over as CEO, or this is what we thought was best. Make sure you are looking at other health centers in your area, but you're also talking to patients and determining if that is reasonable and affordable for them. So really that patient involvement is key, and some sort of documentation for that is what HRSA would love to see. Those are the main areas that I see people have problems with.
Awesome, thank you. Another question is, how do you get a better response from those sliding fee patients on that survey? I don't know if we want to clarify, we're talking about the survey initially or the survey I think you were talking about where you put it at the bottom of the patients that are enrolling in that sliding fee survey when asking if this fee is nominal. I think either or on that one.
Either one. Again, handing patients surveys when they're in the clinic, sending it out, making sure it's in a language and in a way that they can understand that it's culturally and linguistically appropriate. I've seen surveys go out via text message. I know I hate doing them as well, but sometimes if you can have people complete them right there, that's sometimes the best feedback that you can get. So handing them to them, can you please complete this before you leave the site? Also, picking some patients and maybe doing a meal and a meeting about it with some of your board members. I love to incentivize people with a free dinner. Sometimes that helps get people there to solicit their input and involve them. That's also a good way to see if people are willing to come and provide good input. That's kind of a way to screen potential board members in the future. So to see if you can get them involved. If they're not willing to come to one meeting, or if they cause trouble at the one meeting they do attend, that may be a way to tip you off that, hey, you might not want to ask them to join your board in the future. So again, just trying to involve board members. And also I have people that do it. They have patient meetings and they fail to document it. So make sure that you're taking minutes, you have someone there taking notes and or attendance. So that way you're showing that you did meet with patients and you tried to involve them in this process.
Perfect, thank you. And last question, please feel free to continue to drop those in the chat if you have more. The last one that's rolled in so far, we've been mentioned it briefly, but does this apply to RHCs?
Yes, it does. It applies to rural health clinics, especially if you're getting National Health Service Corps scholars, if there's certain grants that you're getting, and you actually are expected to have some sort of charity care. It is not maybe as strict with patient involvement as FQHCs are, but yes, you need to have some sort of charity care, fees based on family size and income, some sort of sliding fee scale to meet the RHC requirement. So yes, it does apply to them as well. So
perfect. Thank you. Again, feel free to drop any questions in the chat or unmute yourself. But for now, that is the last question that we've had. On the screen, we have Elizabeth's contact information as well as a QR code that will take you directly to our website. If you have any questions following this presentation, if you think of them later, like I mentioned at the beginning, this is being recorded and will be posted on our YouTube page. And if you registered for this session, these slides and the recording will be emailed out to you tomorrow. But again, if you have any questions for me, questions for Elizabeth, feel free to ask. But if not, thank you so much for joining today. We hope you at least learned one thing to take away and put into your practice from now. Thank you so much.